Right, it's 3 o'clock. Good afternoon, everybody. Good afternoon, and welcome to the Child Health Priorities Association webinar this afternoon, looking at the best buys to address child malnutrition in South Africa. Really excited to have this webinar this afternoon and the guests and the input. I'm going to hand over to Nozipho Muzuka, who's one of our executive members on the Child Health Priorities, to introduce our panelists and get us started on the webinar for this afternoon. So Nozipho, over to you.
Thank you, Dave. So as Dave was already alluded to, welcome to the South Africa Child Health Priorities Association's webinar on best buys for malnutrition. So thank you for taking the time to join us. And just as a brief background, the Child Health Priorities Association is an advocacy group that is committed to supporting and promoting child health in South Africa. So my name is Nozipho Msakwa, a member of the CHPA, working as a researcher. And just to get us started off, according to the South African Child Gauge 2024, was released a month or two ago, 1 in every 25 children dies before their 5th birthday. Of those that survive, 71% live below the upper bound poverty line in households that do not have sufficient income to meet their basic needs. And then 29% of children are stunted, which is a sign of chronic malnutrition that compromises physical growth and brain development. And less than half of 4 to 5-year-olds attending learning programs are developmentally on track. So in this 60-minute webinar, we hope you learn about the best buys or double duty interventions and what the South African government can do given the resources it has available, the priorities they might take, and what it all means for future generations who must not suffer through these ills. So to make sure we are helping you as best as we can in this best buys topic, we have some housekeeping rules. One, the webinar is being recorded and it will be put on the CHPA website. And may you please put any comments and questions in the Q&A section, which is at your right hand at the bottom. And you can post these questions and comments, and we'll ask the speakers after the talk and to answer some of those questions and discuss some of the comments. So now to our speakers today. We have the pleasure of hosting Dr. Shoaib Kuchali, who's an epidemiologist and community pediatrician. He serves as the academic head of the Division of Community Pediatrics at the University of Witwatersrand and Chris Hani Baragwanath Academic Hospital. Dr. Kuchali works across various sectors and departments and passionately advocates for children's rights to access quality healthcare. So he has contributed to several national and provincial policies and has supported the implementation of various child health programs. So he'll be our first speaker. And then for our second speaker, it's Dr. Lisa Jameson, who's a senior researcher at the Health Economics and Epidemiology Research Office. She has 19 years of experience as a biostatistician and health economist, covering a wide array of topics such as HIV prevention and treatment, TB screening, diagnostics and treatment, STIs, and COVID-19. Her work on the South African HIV investment case has informed national government policy, including the South African National Strategic Plan for HIV, TB, and sexually transmitted diseases. And then our third speaker for today is Dr. Akim Tafadzwa-Lukwa. He's a mid-career health economist who currently works at Hero as well. He holds a PhD in public health with a specialization in health economics. So Akim's expertise spans cost modeling, resource tracking, and health financing. He has published extensively on the socioeconomic inequalities and double burden of malnutrition, particularly in sub-Saharan Africa. So his research highlights the need for targeted interventions to address both undernutrition and obesity with a focus on cost-effective, evidence-based strategies to improve health outcomes. So right now, I invite Dr. CHPA to start sharing and discussing the best buys.
Very much, Nazipo and the Child Health Priorities Association for the opportunity. So let me just get going. Let me know if the slides are visible.
They're visible. Thank you.
Thanks. So my intention for this particular session, or this part of the session, is to introduce ourselves to what do we mean by best buys and addressing childhood malnutrition in South Africa. So before I start, traditionally, I'd like to really thank everyone that really is working tirelessly to help, the lives of our children make them better. But specifically to the Institute of Children's Institute at UCT for doing the remarkable work that Nazipo introduced, and the presidency that also made sure that some of the elements of what we're going to talk about implemented to some level of reliability, and you will see through some of the evaluations that have been done, and then various other individuals that have contributed to the kind of thinking that we're going to be presenting. So, in as an outline, I'll set the scene by the usual aspects of understanding the problem starts off by understanding in which in where we actually play and work, especially with children. So I'll try to give a very quick overview of the system in which this particular topic is actually playing itself out. We'll run through some numbers. We'll see the size and scale it out. We'll look at some of the causes and the root causes of some of these issues that come up as the double burden of disease amongst children, especially in this transitioning South Africa that we're seeing as well. I introduced the concept of nutrition-specific and sensitive interventions as it was known or is still known, but then introduce the concept of best buy as a repackaging of these type of interventions, and then I will try to agitate us to think a little bit outside the box and what can we do to get it going, and lay the foundation for the part 2 section on the return on investments on these best buys that we will agree upon. So let's just get started. I just want to throw this slide in, and I think it may be instructive to just look at it quite carefully. And on the left-hand side, you'll see that the population density map is very startling, and it's not very difficult to then assume and make some assumptions about where people live, where people work, where people go to school, where people eat, play, etc. And some of the very, very stark statistics in the middle there that tell us that we have a very healthy pot of money, but that pot of money still is not reaching the type of child that experiences these social ills, and hunger being one of them. So just a quick run through of this. This is something that I was very, very surprised when I looked at the food and agriculture reports that come out on an annual basis. Only 12% of the land is arable and is usable to grow food and animal products. But only 3% of that is actually premium land for agriculture. 80-90% of it is a commercial land. That means the balance of it is actually traditional communal land, and it's not used specifically for agriculture, even though it's marked for agriculture. There are many socio-political reasons for that as well. And almost all of it, all of the food that we actually produce in this country comes from this 80-90% of the land, which is 3% of the premium land, which is 12% of the entire surface of our country. So it's not then surprising to see that where food is being grown and produced, it's not where food is being consumed and available for people to actually survive. And startling statistics that tell us that South Africa as a whole, when you just look at it, it's a self-reliant country. We don't import a lot of food. We are self-reliant on food supply. We don't have a debt with the World Bank or IMF, etc. So as a country, we are actually a healthy looking institution, right? but millions of households and children actually go hungry to sleep. This is another one that really looks through the lens of how is access to basic and referral care provided. And it turns out that every year on the government websites, you will see that South Africa produces a report to attract investors, attract foreign investments, and so on. And they produce these guides on health, on agriculture, and so on. So on the left-hand side, we see how the greener the part of the country, the more the less the person has to walk to access a health service. And you can see as we're moving from left to right, we are actually becoming better and better. But then suddenly we start seeing startling realities of inaccess as we get closer to current side. On the right hand side, that's just showing the same thing about population density and the distribution of health facilities by density, and it's more in line and correlated with it. This is just to show us that we are not really that bad when it comes to service delivery and accessing the services and so on, but then we still need to know why we are still having these issues. So two nice publications that come out of the Children's Institute, the first one on the left-hand side that really synthesized the information up to 2020 and projected some kind of reality for 2024, which is on the right-hand side. And I would advise that we actually look through these very, very important documents as advocacy tools for us as we work through. So see, here are some of the findings. And I like the title of this, Stop the Slow Violence of Malnutrition. And what they're really talking about here is that South African children are not just stunted, they're not just short for their age. As Nozipho said earlier on, this has a massive impact on the way they are growing, they're feeding their brains and contributing later on in their adulthood as economically productive adults and breaking that cycle of poverty, unemployment, and food insecurity. But we also have a secondary problem that coexists. This is the part where I think this particular presentation is going to focus on, is the dual burden or double burden of having an undernourished child and an overnourished child. But there's probably no better way of saying this, but we shouldn't be using the word overnourished because there isn't a state like that. It's actually overweight and being obese, which is a pathological state of being. And this particular child health gauge went into identifying the root causes, which are labeled on the right-hand side: unhealthy food environments, and my colleagues will talk a little bit about that and how there'll be steps in mitigating all of that, poverty and inequality, and social protection, especially in shocks like in COVID that we have just come out of in the last 4 to 5 years. Again, not to rehash what Nozipho has already said, we are not really where we ought to be. That's the long and the short of these child health graphs that I'm showing here. So the first part is looking at the foundation under which we are going to be building on is there, it is present, it is available, it is sometimes accessible, but it's not always translating into an effective means of measuring the outcomes that we see on the right-hand side. And this is not, again, very surprising. And this has been said over the last 4 to 5 years that we are almost stagnated when it comes to, in fact, may have even gotten worse after the COVID epidemic. So size does matter. I know that over time we may get the feeling that size does not matter. So what size are we talking about? And if we look at the child health gauge that measured the performance across the decades, stunting has actually gotten worse. Overweight has marginally gotten worse, but has not gone down. Obesity is in children on the left-hand side is more or less sitting in the range that is already alarming at a public health level, and then micronutrient deficiencies are still persisting, and so on. These are the same children that were around that are now going to become adolescents and adults who are going to carry the load of a very bad start on nutrition and development that become obese and overweight and contribute to non-communicable diseases listed above. I like this quote here from Dr. Noon. She says, children eat the same food every day, starch every day, starch every day, starch. So this is a quote from the work that they've done in it. So you can see the aggravation amongst people that perhaps the land of the plenty that I drew the picture of, which is on the right-hand side, you can see that somebody went to Woolworths to get that, but it's actually not. This is something that's actually grown in our backyards, and that backyard is not accessible. Food is not accessible to the masses of the people. So two simple statistics. Number one, we are not having dietary diversity amongst children who are in their complementary phase. At least more than 75% of them are not receiving a good dietary diversity score in their diet. And the second one is the minimum acceptable diet, also known as MAD. Yes, more than 75 don't. So that tells us something, that as they wean off their breastfeeding, and if they were lucky enough to breastfeed and fortunate enough to breastfeed, they actually enter the next cycle, the next phase of brain development at a disadvantage, and grow up to become stunted by the end of the 5th year. It's also surprising then, I mean, I put the pause here and I said, but hang on, don't we know what needs to be done? And can this not be fixed? And we know what needs to be done for pregnant women. We have systems in place for that, infants and young children as well, and older children and adolescents as well. All of this is not brand new to us. We know about the first 1,000 days investments. James Heckman, the economist that won the Nobel Prize in 2000, made it very clear to governments that investing early in from conception to the first 1,000 days postnatally actually pays off better dividends and yields better results in it. So I'll keep this question here, but don't we know how to fix it? And the gauge goes further by describing how to protect the child through a very comprehensive response that requires a multi-system level response. And just to summarize that is what needs to happen if all of these elements have to click together and protect the child. These levers have to work in tandem, that if one cogwheel moves, the other cogwheel has to move. So then what's the problem then? So I dubbed this the wheel after wheel. So we keep reinventing the wheel after wheel after wheel, and we all go round as in obese. And that's the sarcasm part of this. So we keep reinventing wheels, we keep talking about it, we keep saying the right things, but on whose ears are these and whose hearts are these messages landing on? So 2 conceptual frameworks have been proposed for this. We know that the 1990 conceptual framework that WHO talks about and UNICEF has adopted, and I'm not going to go through that. I think this is quite clear to many of those who have been working in the field of nutrition. But the one on the right-hand side is from the child gauge, and it talks about the same wheel, and it starts off by talking about issues around birth, 6 months, 2 years, 10 years, and into 25 years, and speaks to this here. So I remember when almost 10, 15 years ago, I had put up this slide in the center on malnutrition, and at that point, I think we were thinking we don't really have that problem. And I think we have a problem of wasting more than we have a problem on obesity. And it turns out that there are more overweight and obese children than there are children who are underweight as a result of wasting, at least in magnitudes of 10-folds, right? So it doesn't really add up in our heads to say that we should ignore the one and focus on the other. We should actually have a double duty responsibility. And this double duty responsibility was not just discovered recently. And it was to my surprise that the WHO, UNICEF, IFPRI, the International Food Policy Research Institute, had published this in 2000 with a projection to 2020. And you can see from the left-hand side what would have been the curve in the number of underweight children that are below the age of 5. And you can see if we did something at that time, we would have been at a different trajectory. And the conceptual framework that shifted away from unilateral dimensional to a much more comprehensive multi-system and multi-dimensional approach. And then we keep making more and more promises. More and more promises come out every year. This is one from this year. The Global Report on Food Crisis under roll-up is a roll call of human failings, right? It's a world of plenty. Children are starving to death. What is needed is actually using the data as advocacy tools that land on the right plates, not the kind of plate that we're talking about, the right plate where we apportion budgets and so on and make things happen a little bit better. And they go through a lot of issues on how mechanisms of how to mobilize these resources and making sure. So you'll see from the center here on food environments, you can see here how many times have we seen shops that look like this in the middle, rather than marketplaces that look like this, where food is really accessible and affordable and nutrient dense rather than energy dense. And we now know, based on the Essential Nutrition Action, the work that has been done on double duty actions by WHO, I'm going to focus on number 4 here, potential candidates for the double duty, which have been exemplified on the right-hand side. Now, again, don't we all know this? Isn't this already part and parcel of our vocabulary? So what is going on? Why are we not meeting the requirements? So when we look at macro systems and big systems that are interacting together with microsystem and mesosystems, you will see that at the level of business, where money exchanges hands and where we are using market forces to decide what sells and what doesn't sell, we have to participate in that process as activists to say that when we do sell products, we fortify them, we create an environment that is protecting the health and well-being and of the children. So this is from the Lancet that was done. And my colleagues are going to speak a little more about these elements of the interventions. So 2 pieces of work that have happened since 2017. Number 1, I just want to draw your attention that 2017 was when the Food Security Plan was established, National Food Security Plan, and then 2023 was the evaluation of it that was done last year. So if we just do a quick mental assessment here, do we have a legal and policy framework? The answer is 10 out of 10. Do we have budgetary frameworks? The answer is 10 out of 10. Do we have an integrated development plan that actually brings water, sanitation, agriculture, land, rural development, job creation, etc.? That's another 10 out of 10. And then there's a new one. They just created one. When I say they, these are policymakers who want to make sure that there is an integrated response to that. And it's called the District Development Model, the DDM. And you may have heard of this within your working environments as well. My question really is, right, is where is the C in this community, in this plan? Where is the collaboration with communities, communication, coordination, co-creation of a plan? It's all about making sure that these elements of a response include communities and their voices up front. So this analysis from the 2023 implementation showed the following. 1, access to food and nutrition is a huge issue. Nutrition education, especially when it comes to the frontline healthcare workers, is suboptimal. Healthcare interventions are not effectively integrated into the nutrition screening and intervention program. Government policies and implementation are vastly what you call disparate and are working in silos and are not integrated to respond. Again, we keep asking these questions, but how much more analysis do we need to do? It almost feels like we have gone into an analysis paralysis before we can actually make another policy on how to coordinate a system and refer patients and refer cases that are on the tail end of the cycle of malnutrition and poverty. The question for us now is, what can we as health professionals do, as doctors, interns, nurses, dietitians, faith-based organizations, people already in the community, The National Treasury has already done something. National government is already doing something. How much more is required for us to do? Here's a nice example of the Western Cape's draft response to the best buys that we've already covered. And they've got a very, very elegantly prepared plan. And are these plans realistic? Are these plans going to make a big difference when implemented? How much more implementation is needed? This is the barrier. The barrier is that context matters. And in these children that are living in very difficult circumstances are actually not getting the benefit of a very rich, plenty, and budgeted, planned, and well thought through process of delivering these best buys. They are not getting it. And the question for us is, why are they not getting it? And Chris Desmond and the team have done quite a very good analysis of the problem, flipping the conceptual framework on its side and then focusing on how we can move away from determinants and analysis paralysis towards making sure that we are looking at solutions on the right-hand side by giving a dollar amount of how much it will cost to actually get a return on our investments in that. And they go through this. I'm running out of time, so I'm not going to cover this.
Can you bring it into land?
Yes, I'm gonna stop now. So these are the best buys that we talk about on intervention. Thanks, Dave. What happens if we don't act? And we can see here, if we don't act, we're going to start seeing shifts away from the interventions that we know actually work. And sub-Saharan Africa is at risk of this. Lise and Akim will cover this in a lot of detail. My last point, we talk about low-hanging fruits and best buys and essential nutrition actions. And many of you will be saying, yawn, you know what? We've been talking about this for so many years. I agree with you. And the point about this is, the longer we look at the fruit and it just gets rotten and festered, the more we are going to be paying for in the future. So I want to leave you with this paragraph, this sentence. The conditions that cause children to die, remember we were all about survival for the last 30 years or so, conditions to die are the same ones that actually determine if they thrive. To improve human capital, which should be the outcome, not malnutrition, and drive economic growth, which should have been the outcome, not malnutrition, we must change living conditions from the conception to adulthood, human development framework adoption, and make sure the human potential is achieved. Moving away from malnutrition and obesity, which malnutrition is used, then becomes a measure of our success, not the conditions we can afford to live with. Thanks, Dave. Thanks, everybody.
Brilliant. Thank you so much. There's so much there to chew over and to look through, and I'm going to need to go through those documents a bit more carefully and a bit more slowly. Really is some challenging concepts and ideas there. Shall we hand over to Lisa and Akim to take it further and to look at some more applications of this? Lisa, over to you. I think you're on mute still.
Hi, sorry. I just want to make sure I'm sharing the correct screen. Can you see my slides?
That looks good. Thank you.
Okay, great. Okay, so yeah, thank you, everyone. So Akim and I will talk through some of the economics of these best buys. Prof. Shoaib has done a great job at sort of, giving us a slow run into all of this and a lot of the topics we're going to cover. So we have some data, and we know a lot of this. This data has been going around for a while, but a recent study that was published in the Journal of Environmental Research and Public Health looked at household surveys across 10 different sub-Saharan African countries and found what we call the double burden of malnutrition, which includes stunting, wasting, underweight, and overweight, to be quite high across all countries. You'll see South Africa sits at around 15.5% based on the most recent household survey. And this is around the average for the region of the countries that they've covered. And also, just to add some more context to South Africa specifically, we know food inflation has skyrocketed over the last couple of years. Particularly here, which is striking, is the CPI headline inflation. So this is a year-on-year inflation in the consumer price index. This is what dictates our social grant increases every year, our salary increases every year. And just in comparison, what has been the food inflation like? This is astronomically much larger, right? It's been better in the last couple of months in 2024, as you can see there, but of course we're still suffering the effects of what's happened in 22 and 23. To put this in a little bit more context, looking at specifically at the price of eggs. So this is from the Lifa La Bantwana, and they show results, specifically data from the South African Poultry Association up to 2023 and retail prices in 2024. So what you could pay, what you could buy for 17 Rand was 14 eggs back in 2019. And food and prices have increased so much that in 2024, you can only afford to buy 5 eggs with the same amount of money. Food and prices have increased 39% over this period. And eggs is a really good example because it's a staple protein for many households in our country. So again, what are the best buys? According to the World Health Organization, best buys are cost-effective interventions which prove to deliver significant health impact for a relatively low cost. In conjunction with this, we're looking at double duty actions. Now, these are interventions that can address both undernutrition and overnutrition at the same time. They target both ends of the spectrum, and they can do this because they have shared risk factors. And we can leverage these shared risk factors, such as poor quality diets, poverty, lack of education around healthy eating. If we can address these shared risk factors, then we can tackle both undernutrition and overnutrition. So what are the best buys? We'll get into more detail for each of these. There are 6 best buys. These are breastfeeding promotion and support, fortification of staple foods, school feeding programs, regulation of food marketing to children, healthy food environment policies, and then maternal nutrition programs. And I'll tackle each one by one and show you a little bit of data on each one, just to sort of, pique your interest and give you some information about what impacts these might have in the population. So breastfeeding promotion, this is encouraging exclusive breastfeeding for the first 6 months of life and continued for up to 2 years or beyond. It's got a double duty impact, so it addresses the risk of undernutrition as well as maternal obesity and actually child obesity, as you'll see in the next slide, some of the evidence. And it's a low-cost intervention, has high returns on health, improves cognitive development, and leads to long-term better educational outcomes and productivity later in life. This is all known evidence for this specific intervention. The Department of Health actively promotes exclusive breastfeeding. As I mentioned, it reduces the risk of undernutrition, and there's also improved immunity. There's lots of many benefits. I'm sure I'm speaking to an audience who knows all of these. It also decreases the likelihood of childhood obesity, maternal obesity as well, and then also reduces chronic conditions later in life. And again, it's this double duty, right? This dual focus. It can tackle both undernutrition and obesity. But breastfeeding, exclusive breastfeeding has always been difficult. It is a difficult thing to do. There aren't the systems in place and structures and social things around us, employment, all these factors contribute to a mother's ability to breastfeed for as long as possible. So you can see that this is data from, on the left-hand side, you can see data from the Witkoppen Clinic here in Johannesburg, and they looked at around 8,000 women over 2015 to 2018, and you can see how many. So most people plan to breastfeed while they're pregnant. They all want to breastfeed, most of them. But then this reduces. So by 7 days, how many are still breastfeeding at 7 days postpartum, 6 weeks, 10 weeks, 14 weeks, and 6 months? And you can see it slowly drops off. And then we also have this huge drop off between 14 weeks and 6 months, likely driven by, many women get 4 months maternity leave, and this could explain why there is quite a substantial drop off by that stage. There was a paper that in the Journal of Pediatrics, which looked at the impact of breastfeeding, and the impact on child mortality and economic cost in sub-Saharan Africa. And they looked across several countries and did the analysis. This is from a macroeconomic standpoint, and then found that if we could improve exclusive breastfeeding rates by 10%, we could reduce under 5 mortality by 5.6%, And this could translate to a $1 to $2 billion reduction in total non-health gross domestic product loss. So basically, we can improve the GDP if we can improve exclusive breastfeeding. And this is essentially because you don't have children under 5 dying as much, and they can contribute to the economy in the longer term. And to improve exclusive breastfeeding, there's many factors, as I mentioned, that can contribute to this. But we need to start thinking about how we can even improve on this. And there are many interventions that look specifically at this. This is just one of them that looked at evaluating the cost of training and supervising community health workers in engaging within the communities to encourage exclusive breastfeeding, help new mothers on breastfeeding techniques, and to encourage and improve the exclusive breastfeeding. The second best buy was fortification of staple foods. This has been going on for many years in South Africa, and essentially it is exactly what this says here. So fortifying foods like maize meal, wheat flour with essential vitamins and minerals. It addresses micronutrient deficiencies in the general population, and it is a very cost-effective strategy. It is extremely scalable, and it has had proven impact on reducing anemia and other nutrient deficiencies. So I'll quickly run through this in the interest of time, but in terms of the 20-year history, I mean, this has been going on for many years prior to 2003, but there's been, since 2003, we've had mandatory fortification of maize meal and wheat flour specifically with vitamin A, folic acid, iron, and other micronutrients. In the mid-2000s, we've already seen some early positive impacts on reducing neural tube defects and anemia, but there still has been some gaps in folic acid intake. There have been policy reviews to show the need for improved compliance and monitoring and public awareness of food fortification of foods. And then in 2016, there has been an increased monitoring and enforcement efforts addressing compliance issues with smaller mills. So just trying to get to the very last few manufacturers, agriculture, to try and make sure that there's compliance with the fortification regulations. In 2019-2020, there were some discussions on expanding fortification to other foods, improving the nutrient mix to cover iodine and calcium. And of course, the COVID pandemic highlighted the importance of fortification of foods to improve food security. And there's an ongoing focus on strengthening enforcement, expanding fortification, and improving awareness to reach vulnerable populations. And we know food fortification programs are cost-effective and feasible. They're also very impactful. There are many studies that have looked at this. Here are just a few, just as some examples. But this is extremely scalable, cost-effective intervention to do. The third best buy was school feeding programs. Don't want to delve too much into this slide, but we know that the South African school nutrition program is up and running. It started around 1994, and its aim was to provide nutritious meals to children from low-income households through the national school program. In 2004, it expanded to secondary schools, so it reached more learners across the country, and it provides nutritious meals to children in low-income households. The focus has been on undernutrition, providing kids with at least one balanced meal daily. And this would have not just on their nutrition, but also improve on their learning outcomes and physical development, helps children concentrate in schools and so on. That it's had a lot of impact so far. There's also an educational component, so it integrates lessons on healthy eating and balanced diets, long-term prevention of overnutrition and obesity, and there's an ongoing impact ensuring food security. It supports cognitive growth and instills lifelong healthy eating habits in children. So it's a very well-rounded program that has grown substantially. So on the left-hand side is the actual expenditure between, this is a bit older data, but it just gives you an idea of how much it's grown from 2010 to 2015. So the spending on the National Nutrition Program was sitting around 3.5 billion in 2010. And it increased up to 5.5 billion rand by 2015, covering 76% of learners in public schools. And as of 2020 statistics, it covers around 9.6 million children nationally And the current 23-24 budget allocation from the Department of Education sits around 9.2 billion, just in contrast to the 2015 value there. You can see it's grown substantially as it's tried to keep up with it's the growth of the program, the food inflation, and everything else that happens in between. There was a study published in the Frontiers of Public Health that looked at the broader economic value of school feeding programs in low and middle income countries. And they essentially evaluated the programs across 14 countries, including South Africa and many other countries within the region. They estimated the costs and benefits across health, education, social protection, and agricultural sectors. And they found that the overall benefits of school feeding are several times greater than the returns to public health alone, and that the overall benefit cost ratio, which Akim will talk a bit more about later as well, what this means, of school feeding programs could vary between 7 and 35. So what this means is whatever money you put into the school feeding programs over the longer term in the economy, you will get back 7 to 35-fold more money, essentially, of your investment, given how the impact on the GDP and the economy overall. Looking at the fourth best buy, regulation of food marketing to children. So this is specifically related to restricting marketing of unhealthy foods and beverages to children. It helps prevent childhood obesity, unhealthy eating habits, and it does reduce the long-term healthcare costs associated with diet-related non-communicable diseases. A little bit more on this. There was a report from UCT, from Desiree Lewis and colleagues, looking at the corporate fast food advertising targeting children in South Africa. Below it is an image from a fast food chain. It's certainly not the only one. I don't want to just target them, but this is from an advert, a screenshot from an advert that was released on YouTube 2 months ago. There definitely is targeting children in South Africa, and this is all what this report was about. I couldn't find data in South Africa looking at this, but in an Australian study, they looked at the cost effectiveness and equity impacts of restricting television advertising of unhealthy food and beverages to Australian children. And they found this intervention likely to be cost saving, with a 1.4 times higher healthcare cost savings and a 1.5 times higher health benefits in the most disadvantaged socioeconomic group. Just of interest, happy to review data if there is from South Africa, but I could not find anything. But I thought this was interesting to point out. And then looking at this, we can use technology as well to assist with this particular intervention. So there was a commentary in the International Journal of Behavioral Nutrition and Physical Activity that came out recently that discussed the use of artificial intelligence, using artificial intelligence to assess food marketing to children on digital media and support the efforts to monitor compliance with policies that restrict its marketing. I think, in the past, things used to be a lot easier. We didn't have so many different channels to go through in terms of advertising, and now we've got, it feels like thousands. You can't escape marketing. So, using technology to our benefit in order to monitor these policies would be ideal. And then on nutritional education, sort of falls in line with marketing. UNICEF launched a My Body, My Health, My Wealth campaign, which promotes healthy diets, physical activity, and mental wellness. And the real implication of this is to promote youth. The youth take lead in raising awareness about healthier food. It's got a nationwide reach, and it also supports the national strategy for prevention and control of obesity. I'm going to hand over to my colleague Akim to take the rest.
Thank you so much, Lisa and Shwab, for providing a very detailed context around this. It's quite interesting that today, since morning, I've been speaking on nutrition and food insecurity. So I'm happy to be part of this webinar. So basically, just to support what has been spoken about by Shwab and Lise, I mean, best buys relative to malnutrition, specifically in children. I mean, this intervention looking at an example of the SSB tax, the sugar sweetened beverage tax, which was targeting to ensure that there are subsidies to healthy foods like fruit and veg. This ensures the double duty that is actually attained in terms of reducing consumption of unhealthy food, as the SSB tax would make sure that the sugar sweetened beverages are actually typically a little bit more expensive than normal. Next slide, please. Okay. Thank you. So a lot has been done as well in the South African context, considering the best buys. Just looking back at the salt reduction in processed foods policy, which was the policy started in June 2016 with the legislation mandating the maximum sodium levels in processed food. So it was introduced in 2 phases with further reductions in sodium levels required by June 29. You see from this paper, they actually showed us a little bit of evidence of what we have gained so far after the introduction of this policy. Next slide, please. Yeah, so for between 2015 and 2019, a study done by Charlton and colleagues actually found that salt intake decreased by 1.16 grams per day between 2015 and 2019, showing some sort of like early impact of the policy. And as of June 2019, further data on the population level effects actually reflected that sodium targets implemented from June 2019 are still needed, which means as much as we've got those policies in place, there's still much to be done in terms of their implementation as well as tracking, so that we could get a sense of how far we've gone since they have been introduced. Next slide, please. And then looking at maternal nutrition programs, the idea of this intervention is to try as much as they can to provide micronutrient supplements, nutritional education, as well as weight management services during pregnancy. And looking at it from a double duty perspective, it targets prevention of low birth weight, childhood stunting, while addressing maternal obesity as well. And in terms of the economic perspective of this intervention, it reduces the incidence of costly neonatal complications and long-term development issues, which we might realize, or we will realize, as public health gain in future with a healthier labor force or productive labor units. Next slide, please. So maternal nutritional programs such as ANC services offered through the South African public health system provide pregnant women with nutritional support and supplements, for instance, iron and folate. And this is quite crucial in preventing stunting and low birth weight, as I reflected on the previous slide. But however, one thing that to note is it's also an important intervention in reducing the risk of gestational obesity and diabetes, which are main contributors of overnutrition. So these services aim to ensure health pregnancy and reducing malnutrition among newborns, which is also quite a problem, as what Lisa has reflected on one of the first slides during the presentation, where she was showing the double burden of malnutrition. South Africa, from the 10 selected sub-Saharan countries, I think it was ranking around number 5, 6 there. So it's quite fascinating to understand that those best buy interventions also play an important role in reducing DBM. Next slide, please. So a lot of work has been done, although we couldn't find a specific South African example. I'll only talk more in detail about the return on investment on one of the studies that we came across. But maternal nutritional programs have been proven to be cost effectiveness, with studies done in India, Pakistan, Mali, Tanzania. Even although it was a microsimulation, it showed that microsimulation, meaning it's a modeling study, even with those estimates, it actually showed that it was cost effective. Next slide, please. So these are some of the things to consider in terms of the health econ aspect when it comes to best buys, government funding and budget allocations. I think one of the things that we struggled with Lisa when we're preparing the slides is we couldn't find a specific line item, be it on at provincial level or at national level, where money was actually allocated to tackle child malnutrition in South Africa. So it will be interesting if is that specific allocation as a line item within the health budget. And also public-private partnerships would really help in making sure players for food fortification and other scalable nutritional interventions collaborate together to see how best we could ensure that these best buys are practical and implementable. So in terms of the cost-benefit analysis, I'm just going to skip this. I'll speak this in detail as it's one of the examples that I'm going to run through. Then considering that now we're currently talking about the energy.
Akeem, can you start to wrap it up now?
All right, sure.
Brilliant, thanks.
Health insurance and social protection schemes also are important in terms of targeting nutritional-related interventions, as well as community-based financing models. Next slide, please. I'll try to explain this in brief as much as I can. So basically, with the return on investment, we are saying this is trying to measure the financial benefit gained from each unit of current invested. Specifically in public health, we're saying for the money that we have invested, how much are we actually gaining, be it in future productivity, reduced malnutrition, or enhanced education outcomes. Next slide, please. So this paper actually showed that there is a lot to lose if we don't tackle malnutrition, both undernutrition and obesity, as losses accrued as a result of malnutrition can be 0.2 to 4.3% of GDP, which is actually a lot, with some studies done in Guatemala and Nigeria, as well as in Indonesia, showing 9.3% higher wages when these nutritional best buys were actually implemented. Next slide, please. This is the study that I wanted to focus on in terms of the return on investment, that reaching just 90% of children in South Africa could yield a substantial productive returns of present value of over $2 billion US. However, to note is it all depends with the socioeconomic status quintile that we are targeting, as it requires a lot of money to target the poorest quintile, although they yield similarly low returns compared to the richest quintile because of the disadvantages between children that are coming from low socioeconomic household and children that are coming from wealthier households. Next slide, please. If you look at the last box, which is to my bottom right, with better educational and employment opportunities, each dollar invested in a nutritional program for the poorest child would yield $31 in return. So you can see how cost-effective those things are. And basically, the take-home messages is that context matters in terms of return on investment, and well as nutrition as best buy, early nutrition interventions have been highlighted to reduce stunting and improve health education, future earnings, making them highly cost-effective. And linking health to the economy, investing in nutrition, we've shown the evidence that it enhances productivity and human capital, yielding both health benefits and long-term economic gains. Therefore, there is need to maximize the returns through the highest return on investment, which will be achieved if we prioritize these nutritional interventions paired with better school quality and equitable job opportunities. Thank you. Over to you, Dave.
Brilliant. Thank you so much. Once again, lots of interesting context and some great detail there. So there's some interesting questions in the chat about provision of nutritious foods, therapeutic foods, and then also about the sugar tax. Question from Ronelle: how would the panelists suggest addressing lack of appetite to prioritize this low-hanging, high-intensity fruits, breastfeeding promotion in particular? Akeem, do you want to respond to that? And then Shuaib?
Okay, thank you. So I think, of course, we still have a lot way to go. I was saying earlier in today's discussion, saying it's really difficult if still we've got the sugar sweetened beverages still cheaper than healthy food options. Like now, you could buy a 2-liter Jive way cheaper than a 2 liters of water. So in terms of the SSB tax, because it targets sugary drinks within a specific bandwidth, it's really difficult to implement as well. And people define healthy food differently by context, right? It's really difficult explaining for someone who has been taking these sugar-sweetened beverages for the past 25 years, who has never had diabetes or who has never had any problems, that cultural aspect is really difficult selling out that discussion, as long as it's not part of the nutritional training within communities and also within schools at an earlier level. It's really difficult to sell the idea. So the policy is good, but just because the specific bandwidth only covers probably one of the many problems that we have associated with sweetened beverages.
Yeah. Shuaib, I realize you've got a plane to catch. Do you have any closing thoughts or comments in response to the questions?
So Ronelle raises the question that we are asking today. And I think just to answer that very clearly, the low-hanging fruit related to investing in breastfeeding is rotten, right? That's the simple answer. And I won't go into the meaning of what I mean by rotten. If I have to breastfeed a baby and take him through to 5 years, I would have prevented his admission for diarrhea, pneumonia, malnutrition, etc. That cost is actually plowed back into the system, and later on in 25 years, who's going to think 25 years from now when I have to feed my baby today? So the answer to that question is that it is every one of our responsibility. So if I'm a clinician and I'm seeing a patient who delivers, 98% of our mothers deliver in a facility. That means we have access to this population to start her on a good stance so that she continues. So the investment is now, and it starts with us making the right noises about not formula feeding as an option, but breastfeeding. And there's everything in our favor right now. The question really is, has the decision-making body who is giving budgets to human resource capacity, because that's where time and material is involved, seen this benefit? And I think it can only be seen not through the lens of an economic analysis, which is 25 years from now, but through the lens of let's walk this talk together with somebody who's actually holding the purse strings. So that would be my approach. I know it's quite a direct answer to a very, very difficult question to respond. Many simple population-based studies have shown this. We don't need to go back and do a reanalysis. We now need to walk the talk where we are and where we work, where we play, at school, in our homes, everywhere. And as we start spreading the good news and protecting mothers to do it, we should protect them to do it. So if they're employed, how do we support them if we have a helper at home to give her days to go and breastfeed the baby or bring the breastfeeding baby to come to work with her, and we look after the child together? We are very disparate. We need to close that gap. Thanks.
Absolutely. Lisa, you look like you also had something to contribute to that. Do you want to respond to that question or to what's in the chat?
No,
see Jenny asking a question about pumpy nut.
Yeah, my agreement was just with the breastfeeding and the support women need in the workplace, just from my own personal experience. I'm lucky enough to work somewhere where it is possible, and I am supported, but many women don't have this. And like I mentioned, maybe to Nazipo, I think earlier, is there isn't there's other, I mean, we get 4 months maternity leave, and there's a huge drop off in breastfeeding because women have to go to work and they don't have, like, I mean, either we need longer maternity leave. I'm not sure if I can advocate for that in order to support women to breastfeed for longer, or we need to, workplaces need to come to the party and assist women for, as much as, like Shoaib said.
Nozipo, do you have any responses or questions for any of the panelists before we give them their final minute of airtime?
I actually don't have anything to add to what the panelists have to say. I want to thank them so much. I just wanted to answer Jenny Nash's question, asking, has the politics around using plumpy nut in SA been resolved? Unfortunately not. That's all I can say. I'm just trying to rush through. Yeah, so it still is a very politically, I don't know, what can I say? Nothing has changed, because I think it also comes from the fact of the people who are implementers. If they're saying plumpy nut will cause overweight and obesity, we are producing plumpy nut in South Africa, but we're not giving it to our children. It's a bit of a tricky situation. Thank you.
Brilliant. Thanks for that. Okay, Shoaib, we're closing down now. You've got 1 minute. What is a closing thought for our audience?
We are a country that is in transition. We have to accept that. When I say this, I say it with humility. There are lots of residual challenges that we need to address, but there is a very big monster that's eating all our rotten apples, and we need to be clear about what that is. And as advocates for child health, I'm saying that let's stand up and let's be active about making sure that the right noises with the right data, which is our currency to make the noise, and the right vuvuzelas that we need to make the noises about this, so that when we stand in front of a dead child in our bedsides, wherever in a community, that we are representing their interest of a lack of a voice through the currency of data and the argument for investing in those small cost, high impact interventions. Thank you.
Brilliant. Thanks for that. Lisa, closing comments, final words from your side?
Just to say that there is so much economic evidence for the benefits. We didn't get to spend as much time on it, but the return on the investment benefits, this is, how much money we're getting out in the long term, and growth in GDP, and, improving productivity of the population. That is massive. That is huge. And I don't think we can undersell that in any way. It's what our country needs. We need to grow our economy. We need to grow our GDP. We can't do that if we don't address the malnutrition and overnutrition issues we have in this country.
Brilliant. Yeah, thank you for that. Akeem, going to give you the last word before we wrap up this evening. Any final comments for the people?
Thank you so much, Dave. So the initial message was, people, let's eat. But I think now we've revised the message. Let's mind what we eat. That's all from me. Thanks.
I love it. Thank you so much. Folks, it's just after 4 now. And thank you so much to our panelists for their preparation and their insight, and all the work that they've done to share with us this afternoon. Thanks to Nazipa for all the admin behind the scenes and organizing and running around and doing so much in the last couple of weeks. Really appreciate all the arrangements for this. We are going to post this to the Priorities website this afternoon, this evening. So you'll be able to get the recordings and then access the slide sets from there as well. So from my side, thanks everybody. Really appreciate your attendance and engagement and questions. And we look forward to carrying on this conversation online and as we go forward through our associations and also through our clinical work in the different platforms. Thank you so much. Nosipo?
So I'd just like to thank everyone for attending this session today. Thank you for coming through and, tackling this issue with us. We don't have the answers. We would just say to you, be advocates wherever you are. Advocate. And if you want to join the Child Health Priorities Association, you join. There's no subscription fee. We want to discuss and advocate for children's health. Thank you for joining us today. Goodbye.
Everyone, bye.
Bye.